Hello everyone. In this class, we'll try to learn about what are the physiological basis of ECG. The learning objectives would be to understand the concept of cardiac dipole and how different ECG waveforms are produced, and to understand and draw ECG tracings of normal 12-lead ECG. The ECG records the voltage between dipoles produced by electrical activities of the heart. The ECG is the recording of the electrical activities generated by heart. Dipole is a combination of two poles, that is positive and negative poles in an electrical field. When negative wire and positive wire are placed in a container containing equal amount of charged ions, the positively charged ions flow toward the tip of the negative wire and negatively charged ions flow towards the tip of the positive wire. Though the two poles have opposite charges, they have the currents equal in magnitude. The combination of these two poles that have equal and opposite charges is called as dipole. The voltage associated with the dipole can be measured using voltmeter. If electrode of voltmeter are placed opposite to each other in a horizontal plane between two poles, the voltage recorded is maximum. But if the position of the electrode is changed or the position of the dipole is changed, the magnitude of the vector is decreased and therefore the voltage is also reduced. Thus, the voltage difference that exists between that exists determined by the influences of positive and negative ends of the dipole. In other words, dipole determines the voltage measured at distant points in a volume conductor. In fact, direction of the dipole is relative to the electrodes and magnitude of the dipole, that is the voltage of dipole, are the two important factors that affect the recording in voltmeter. Thus, dipole also acts as a vector. Okay, so this is the diagram showing the positive and negative electrodes, which are having equal number of ions, and they can act as a dipole. Yeah. Our body is a volume conductor, and the electrical activities of heart create many dipoles in the body. As a heart creates many dipoles simultaneously, ECG records the voltage of the net dipole, so which is the average of all the dipoles. The spread of excitation creates dipole. In the process of spread of cardiac excitation, when the impulses excite a region of the heart, that region is depolarized. This generates the dipole. The region of myocardium depolarized constitutes the negative pole, and the region ahead of it, yet to be depolarized, constitutes positive pole. The dipole shifts from one region to another. The heart contains the dipole, and heart is present in the body, so which is a good volume conductor. The electrode located on the volume conductor on the surface of the body records the voltage resulting from the dipole, which is generated by electrical activities of the heart. Why ECG has various waveform? If the position of the dipole changes in relation to electrodes, the voltage recorded from the volume conductor changes. In myocardium, many dipoles are created simultaneously. The voltage of the net dipole, that is average of many individual dipoles at any given time, is recorded in the voltmeter, that is electrocardiographic recorder, which is connected to the 2 points of the volume conductor. So this is the recording that we see in a lead 2 ECG, and this shows summated activities of the atria, ventricular, the depolarization as well as repolarization. So here P wave is because of the atrial depolarization, and QRS complex is because of the ventricular depolarization, and the T wave is because of the ventricular depolarization. Lead 2 records the electrical activity between right arm and left leg, that is point B and point A. According to the principle of electrophysiology, when point A is positive in relation to B, the ECG deflection is upwards, and when A is negative in relation to B, the deflection is downward. The magnitude or the strength of voltage is indicated by the length of the net dipole. When net dipole is parallel to the line AB, the magnitude, the strength voltage is maximal, and when it is perpendicular, the magnitude is 0. Thus, magnitude recorded by the electrocardiographic recorder depends on the direction of the net dipole and the muscle mass of heart involved in generating the net dipole. Accordingly, various positive and negative deflections of the various magnitudes or isoelectric lines are produced in the ECG recordings for various leads depending on the position of electrodes on the body that records the potential difference at a given instant. The P wave in the ECG, it represents atrial depolarization. A synodal discharge spreads over the atria and causes atrial excitation. The magnitude of the net dipole is proportionate to the atrial muscle mass and direction of the depolarization. The voltage change due to atrial depolarization appears on the ECG as a P wave, which is a positive wave with less height and dome shape. The height of P wave is less because less atrial mass and dome shape is due to the slow nature of the depolarization of atrial muscle. When atria are completely depolarized, the ECG tracing returns to the 0. PR interval is it includes P wave and PR segment. It represents atrial depolarization, that is P wave, and atrioventricular conduction, that is in PR segment. The PR segment is an isoelectrical line. During PR segment, the wave of depolarization passes slowly through AV node and then through his bundle. The net dipole created by depolarization of these structures is too small in magnitude to produce any deflection on the ECG recording. QRS complex. The QRS complex represents ventricular depolarization. It consists of 3 waves: Q wave, R wave, and S wave. Q wave is the depolarization wave passes along bundle branches and Purkinje fibers to excite interventricular septum, which depolarizes from left to right. The net dipole of initial depolarization manifests as a small downward sharp wave, that is Q wave. The small wave is due to the less quantity of septal muscle and less time of depolarization, and sharpness is due to the rapidity of depolarization. R wave. The depolarization wave spreads from subendocardial layer to the subepicardial layer. The deflection in the ECG appears as a R wave, so which is an upward, bigger and sharp wave. The R is largest wave in the ECG because the greater muscle mass of ventricles. The sharpness of the wave represents rapidity of depolarization. The R wave returns to baseline when the whole ventricle is depolarized and there exists no potential difference between 2 points of the dipole created in ventricle. The last parts to be depolarized are posterior basal portion of the left ventricle and pulmonary conus. S wave is small, negative and sharp wave. The QRS waves together form QRS complex, which represents ventricular depolarization. The duration, magnitude and sharpness of QRS complex indicate greater muscle mass of the ventricles depolarized and the rapidness of ventricular excitation. ST segment. As soon as ventricular depolarization is completed, all dipoles associated with it disappear and ECG tracing returns to baseline. The ST segment starts from the end of S wave and ends with the beginning of T wave. The ST segment is an isoelectric line. This indicates in this phase dipoles are not adequate enough to create any wave in ECG. This is the phase of beginning of ventricular repolarization. The T wave represents ventricular repolarization. Repolarization is an opposite process of depolarization. Therefore, repolarization should have produced downward deflection in ECG. However, the process of repolarization occurs in the opposite direction to that of depolarization, that is from epicardial to endocardial surface of the ventricular muscle mass. Therefore, the polarity of the net dipole of repolarization is same as that of polarity of the dipole of depolarization. This appears in ECG as a T wave, which is a dome-shaped positive wave of longer duration. This indicates that repolarization is slower than depolarization. The cardiac dipoles as vectors. The cardiac dipole act as vectors in both direction and magnitude. The net vector, the average vector of all cardiac dipoles, can be determined from the ECG recording. The direction of the vectors is determined from the ECG recorded from the leads placed in frontal and horizontal planes of the body. The three limb leads, that is lead 1, lead 2 and lead 3, and three augmented limb leads, that is AVR, AVL and AVF, give information in the frontal plane of the body. The lead records the potential differences between the left and right arms and records the electrical vector at that is parallel to its axis. The axis of lead 1 passes as a horizontal line through the center of the chest from right to the left arm. Similarly, axis of lead 2 passes as a 60-degree line with the negative end of right arm to the positive end towards left leg, and lead 3 as a 120-degree line from left arm to the left leg, that is to the positive end. The axes of augmented limb leads are interspersed between the bipolar limb leads. Thus, the picture of the axis of leads in frontal plane is called as hexaxial reference system. When the net cardiac dipole with its positive charge is directed towards the positive end of the axis of the lead, upward deflection occurs in the recording. If the net cardiac dipole with its positive charge is directed towards the negative end of the axis of a lead, downward deflection occurs. No deflection occurs if the positive charge of the net cardiac dipole is directed at right angles to the axis of a lead. Okay, so this is showing a different axis. This is the axis for the lead 1, this is axis for the lead 2, and this is axis for the lead 3, and the AVS, AVR, AVL, AVF, they are going to intersperse between these three limb leads, so which is going to form a hexaxial vector. The normal 12 lead ECG, the depolarization spread towards the positive pole. There you see positive or upward deflection. The depolarization spreads towards negative pole. The negative or downward deflection is recorded. An isoelectric or biphasic deflection where depolarization starts in SA node and spreads downward to the subject's left. The P wave is always positive in lead 2 and negative in AVR. The ventricular septum depolarizes from left to right, that is towards V1 and away from V6. So this produces a small Q wave, that is septal Q wave in V6, and small R wave, that is septal R wave in lead V1. During ventricular depolarization, as left ventricular mass is more than the right ventricular mass, the net direction of depolarization is towards the left chest leads. This produces tall R wave in lead V5, V6 and deep S wave in V1 and V2. When the heart is more vertical, that is in leads 2, 3 and AVF, show a QR pattern, and when heart is more horizontal, the leads 1 and AVL show QR pattern. The T wave normally follows the direction of QRS complex deflection. In chest leads, T wave is positive in left-sided leads and also in V2, and in V1 T wave may be positive or negative. So this diagram showing all the limb leads, can see in lead 1, lead 2 and lead 3, and the augmented limb leads AVR, AVL, AVF. Okay, so in AVR you can see all the waves are negative here. Okay, and in the chest leads, as you go from the left to the right to the left, the QRS complex is always going to be positive. So this shows the presence of the leads and from which direction they're going to see the heart. Okay. So V is going to see the heart from the right side, and the V6 is going to see the heart from the left side. So this is about the basics of the electrocardiogram in brief. Thank you.